Unfortunately, there's probably about 50 to 70% of patients that we're able to identify the genetics in right now. So we don't know what the rest of the story is. It doesn't mean that they don't have atypical aHUS. I suspect that there are families in this room who have children. In fact, I know there are. Who have children who don't have an identifiable genetic abnormality. That doesn't change the fact that they have atypical aHUS for us. That just makes us more interested in pushing to find out what that is. And particularly, this is kind of one of those things that we talk to other physicians about, if you will. The genetics are not important to making the diagnosis right now in terms of treating that child that's in the ICU or that's in the clinic setting right now. The genetics are not important to making the decision to start initial therapy. The genetics are going to be much more important for a lot of other reasons, which we'll talk about in the rest of the sessions today. But the point is that there are absolutely children who do not have an identifiable genetic mutation, but they still have atypical aHUS. And even if they have unfortunately, even if there are, in some patients, if we have an identified genetic mutation, we don't have disease because of this last point here, the penetrance. And that's just basically, that's our term that we use for the fact that only 50% of those, as best as we know, and again, you keep hearing me say that, I'm sure, but as best as we know about those, even if you have the gene and you have only potentially a 50% chance of actually manifesting disease. Now, of course, it depends on the gene, et cetera. There's a lot of things that actually will qualify that. So don't hold me to that 50% too tightly. But the point is that not everyone with a mutation will get disease.